Medicine at St. Mary's General Hospital. I'm very fortunate today. I have a very brief part in this presentation because I'm fortunate enough today to be here with the staff, 2 RNs from our unit that probably know this problem and presentation better than anybody. So I get the joy of introducing them and then passing it over to them. Megan Kresge is an RN in our unit who does charge nurse duty, and Julie Dion is a nurse that's been working within the LEAN program at St. Mary's, helping me to help the staff learn all about it. So the first thing I just want to mention is the vision of LEAN at St. Mary's. I'm palpating. Can you hear it? I do this every time I start a presentation. LEAN at St. Mary's, we have a vision to take a culture and move towards a problem-solving approach. And you know healthcare, we're used to solving problems. Usually it's on the run and in a really fast, reactionary way. So to put a structure, an A3 around it, is totally different for our daily work. And so that's the goal, is to create that A3 problem-solving approach and keeping in mind who's our customer. It's the patient. So on that note, then, how do you bring a culture change to a healthcare group of professionals that are very strong-minded and know their job and think that the way they're doing their job is the way things should process through? So initially with LEAN, to create that culture, I would have to say that from a manager's perspective, it was daunting. How do I bring this down to the staff? Help the staff embrace it, they hit Yahoo, let's go? It's not easy. But if you looked in the window at St. Mary's, what you'll see is that LEAN is at that point of our directors. When you go to the board of directors, you'll see LEAN is there. When you go to senior management, you'll see LEAN is there. And then what they've done is they said, now how do we bring it down to all of the other staff across the organization? So what they've put in place is a LEAN management system. And what I have to say as a manager that's helped me the most is the resources and the support and the linkages to bring that system and that education and coaching down to the staff that I work with every day. And that's why we've already had a really successful project. So looking at this, we want to be proactive in planning and all the points of daily continuous improvement, unit performance and leadership, and sustaining the gains. We know these words, but we don't know what they look like. So our LEAN management system training has helped us do that. And so what is LEAN thinking at St. Mary's? We brought on our first problem approach, and that was to say, how do we make the bed available for our patients? I think any hospital is asking that same question daily by minute. And so we wrote an A3, and we were calling it the mother, because it literally spinned off a bunch of other baby A3s. Now I have to make a point here, because it says there, a pretty good 1, 2. I'm boasting, right? But I have to really give kudos to Andy Reid, who probably, through all the interviews and listening to a bunch of clinical staff, he works within our LEAN management team to help us learn about LEAN. And really our A3 and understanding that came from his perspective of learning about us and letting us tell him what it is we do. So we really got down to the root cause. So kudos to Andy. And so we've written another baby A3 off that mother, and that helped us move forward with our root problem and then say, okay, what can we do with this? So on that note, I'm going to pass it off to Megan, who's going to tell you about our problem, how we process through it, and then we'll also hear some great ideas about what were our records.
All right, so our problem, and this was a big problem to tackle. First, we had to define who our customer was, and that was any patient being admitted to St. Mary's. What was our situation? The current situation was an appropriate inpatient bed for admission is available approximately only 40% of the time. Our desired situation was an appropriate inpatient bed available 100% of the time. So what we wanted to achieve was the gap between the current and desired, and the basis of our improvement project. So our problem statement developed from there was 60% of the time an appropriate inpatient bed is not available for admission. This leads to long lengths of stay in the emergency department. And we will measure the success by a reduction in the ED length of stay for admitted patients. And this is our mother A3. It is a mother. We went through a process to understand why we were having this bed Why were the beds not available when we needed them and where we needed them? So our current situation. In the top left-hand corner, you'll see the emergency inpatient. This was the census of how many patients were actually waiting for a bed in Enbridge. In the top left-hand corner, right-hand corner, sorry guys, was medicine specifically, whether or not there was a bed available. So we see that it dips down in July and August that there was beds available, and then come around October, November, December, and we don't have bed availability. And our bottom graph illustrates a couple of things. This is from an emergency department perspective. Our yellow line illustrates the PIA time, which is the time to see a doctor, from the time you walk in the door to the time you see a doctor. Our green line illustrates, sorry, I'll talk with blue first. Blue illustrates the time from when you actually get to triage to a room behind in minor treatment or subacute or acute care. And our green line illustrates from when you're in that room in an emergency department to when you actually see the doctor. And you'll see at the end here, when our emergency department is in November and December, when we're packed to the gills and we don't have any beds available, the doctors actually become available sooner and can see patients sooner. So we developed a list of 50 or more root causes and why this was happening. And from there, we came up with 20 to be tested with data for root causes. What did we learn? That the impact of bed availability can be traced back to a handful of items. More specifically, the overall discharge process, physician variation in practice, physical bed capacity, and community supports. So we focus on the two that will give us the biggest bang for our buck, that had the most impact. And our final hypothesis, if we fix number one, the overall discharge process, then we may also improve number two, our physician variation in practice. So our targets and measurements. Our ultimate goal was an appropriate inpatient bed available 100% of the time. And our target was to reduce the 90th percentile ED length of stay, so emergency department length of stay, by 25%. In the calendar year of 2013, our ED length of stay was 25.2 hours. And in the target calendar year of 2014, our target was hoping to get less than 20 hours.
So you can imagine trying to figure out sitting in Emerge for 20 hours waiting for a bed. None of us is an ideal situation for that. People don't have family doctors, so that's part of an issue. People aren't using the emergency departments appropriately. So it's a great big problem to tackle. So we came up with our Baby A3. Our 3 is standardized and improved medical discharge, patient discharge planning process. And that became our Baby A3. Going back to the problem statement, and we didn't have a standardized discharge planning process, so we had to make one. Remembering that the desired outcomes, reducing the ED length of stay for admitted patients, that is one of our corporate goals. So we're tying back to that. From this slide, you can see that through the months of April to December, our ED length of stay was greater than 20 hours. No matter what was going on, sort of season by season, that really never changed very much. So that was our focus to try to work on. Current situation and root cause, why were there people waiting in Emerge? Why are there not beds? There's no beds because the inpatients are still in the beds, so that's an issue. Not discharging appropriate or in a timely way. Lack of understanding of patient status definition. We have a lot of people that work with physicians on discharge. Physicians, excuse me if they're in me, like to think that they're in charge of the discharge, not so much. We have lots of people that work with the physicians on it. They're ultimately the discharging folks, but there's a lot of helpers there as well. We had no standards to understand the progress. Physicians subjectively determine overall patient status. They would come to our discharge grounds and either the patient would be red, green, red, yellow, or green, and that would sort of drive everybody to what they needed to do next. Communication on patient status was verbal. Communication on patient status occurred only once a day and was owned by the resource nurse. And again, our target to reduce that by 25%. We redefined red, yellow, and green to be more specific. It's not a time thing. When you're sick, you're sick. When you're getting better, you're getting better. And you can't really put a time on it. So we sat with everybody and tried to figure out what everybody wanted as a customer to be able to do a discharge, get the patient ready for discharge. And everybody sort of had the same kind of ideas, what they wanted. Different information, specific information, what they wanted to be able to discharge a patient. We set out to create a standard process for rounding, and we had a standard of documentation that we created as well. We created a standard work, for each discipline so that we would know when a patient was red, what did they have to look like to turn to yellow, to turn to green, to be getting ready to go home. Our bullet round board, it's not the best picture, but it shows everybody, patient-wise, doctor-wise. Each discipline has a magnet. They put that up on the board when the patient is red. When they're still diagnosing, things are still not clear as to what the outcome is going to be. As things move along, patient becomes yellow, things are getting better, we can involve other disciplines before we can get ready to go home. If there's any meetings and crisis or any other interventions we can include at that point, that's when we would bring those in. And then when everybody's agreed, when the patient doesn't need to be in the hospital anymore, then they're ready to be going home. With the idea that anyone could come to the board and sort of look at it and get a picture that they can see Mrs. Jones is in the red for the physician, so they're still doing some testing. Physio's working with them and getting them mobilizing so that they can be going home. Other disciplines, social work or home care needs to be involved. And you can get a snapshot picture of what things look like. We're including where people come from, where they go, how many days they're here, so that everybody can sort of at a glance look to see where we need to sort of focus our work on. Our ED length of stay correlated to volume. You can see that since we started our project, that the beds are more available. There's certain times of the year where we can look at it now and we know what the problem was. During flu season or during an outbreak at a different place, sometimes that affects our length of stay. So our results for the 90th percentile were 25.4, and we're down to 18.2 hours. It may not seem like a whole lot, but if you're sitting in Emerge, or your mom or your dad sitting in Emerge waiting for a bed thinking, what's going on, this is huge for healthcare. Our average, we've done our ranking in all the hospitals. There are 74 hospitals. We were ranked at number 22, now we're ranked at 17 on this particular thing. So we increased our target to 60%, which is huge for healthcare. Lots of folks maybe are doing better,